Hello, Nina.
Good evening, ma'am.
Very good evening. Very happy to see you.
Yeah,
Hello.
happy to be here on this platform with my old teachers and friends and colleagues.
Hello.
Hello, good evening, Sahasranamam, sir. Good evening, Mini. Hi, Anu. I hope
Hello.
it's the same Anu, which whom I remember. Good evening, sir. Sahasranamam, sir, is there.
Okay, Nina.
Yes, sir. Audio is not. It's not audible, sir.
Yes, I can hear you. Can you hear me?
Yes, sir. I can hear you very well. I have increased my audio sound. I think I'm now audible, no?
Okay, yeah, you are very much audible. You are very much audible. So, I got in early, you know, because because this I badly wanted to get in. But it so happened that last week and I was happy that it was postponed to this Saturday. രണ്ട് കാര്യങ്ങളാണ് ഒന്ന് നമ്മുടെ PGസിന്റെ അടുത്ത് മാത്രമല്ല നമ്മുടെ നമ്മുടെ നിങ്ങളെ പോലുള്ളവരെ we are happy to hear മനസ്സിലായില്ലേ
I'm happy also to be with my
that way പക്ഷെ മാധവൻ സാർ കയറി മാധവൻ സാറിനും ചിലപ്പോ ഇറങ്ങേണ്ടി വരുമായിരിക്കും അതാണ് എല്ലാവർക്കും അപ്പോ എല്ലാരും നീനടുത്തുള്ള സ്നേഹവും ഐപ്പാടിന്റെ സ്നേഹവും കൊണ്ട് കയറിയതാണ് അല്ലേ മാഡം
not only a സ്നേഹം മാത്രമല്ല the way she presents I cannot miss it അതുകൊണ്ടാണ്
അതെ
I'm also honored to be here and to present in front of my teachers. It's definitely an honor.
പിന്നെ അതെല്ലാം anyway ഞാനിപ്പോ മറ്റേ സൈഡില് ലാപ്ടോപ്പില് മറ്റേതും കയറി വെച്ചിട്ട്
exactly that's what I was also thinking.
അതെ
ഞാൻ വേറൊരു സിഎംഇയിലാണ് അതിനിടയ്ക്ക് ഇറങ്ങി വന്നത് ഗോകുലത്തിന്റെ ഒരു ഫംഗ്ഷനും I want to actually hear how Nina asks questions. It's a unique way. I learned from that. And Alan also is a good presenter.
Yeah, definitely.
He's a good student, and we asked our PGs to join and hear his presentation.
Yeah, sure.
It'll be a good learning experience, right, for them.
Yes.
So anyway, I think it's 7:30, 7:39. Can we start now?
അയ്യോ മാധവൻ സാർ പറഞ്ഞപ്പോ ഞാൻ ഓർത്ത് ഞങ്ങളുടെ PGസിനെ ഒന്നുകൂടെ റിമൈൻഡ് ചെയ്യണം ഞാനൊന്ന് ഇതിൽ അപ്പോ നീന ഇൻ ബിറ്റ്വീൻ ഇപ്പൊ ഇത് എനിക്ക് തോന്നുന്നു മാധവൻ സാറേ നമുക്ക് പിന്നെ വേണമെങ്കിലും കേൾക്കാം തോന്നുന്നില്ല ഇപ്പൊ എനിക്കൊന്ന്
റെക്കോർഡഡ് തോന്നുന്നു കേട്ടോ
കഴിഞ്ഞ കുറച്ചെണ്ണമായിട്ട് നമുക്കിപ്പോ ആദ്യത്തതൊന്നും ഇല്ല പക്ഷെ ഇപ്പൊ ലാസ്റ്റ് ഒരു 4-5 എണ്ണമൊക്കെ റെക്കോർഡാണ് ഐ തിങ്ക് വി ക്യാൻ സീ ഇറ്റ് അഗെയിൻ അല്ലേ എനിക്ക് മിനി നമുക്ക് കഴിഞ്ഞൊരു 5-6 പാഠശാല നമുക്ക് ആർക്കൈവ്
സ്വപ്ന മാഡത്തിന്റെ തൊട്ട് മുതലുണ്ട്
അപ്പൊ പിന്നെ 2-3 എണ്ണം അറ്റ്ലീസ്റ്റ് എന്ന് വെച്ച് കഴിഞ്ഞാല് നല്ലതാണ് ബാറ്റ്ലി വാണ്ടഡ് ടു ജോയിൻ കഴിഞ്ഞ ശനിയാഴ്ച അസൗകര്യമായിരുന്നു സം അതർ റീസൺ മാറ്റിയപ്പോ ഐ വാസ് ഹാപ്പി ദാറ്റ് ഇറ്റ് വാസ് ചേഞ്ച് പക്ഷെ ഇതിപ്പോ അപ്പൊ നീന അപ്പോ ഞാനത് കഴിഞ്ഞിട്ട് കേൾക്കാം
We'll start this session now.
Yes.
I have enough people joined. How do you feel?
15, sir.
Then we will start we need not delay. So as president of the RIO Association, I welcome everyone for this. It's almost a flagship program now for the RIO Association. They are running regularly well. And so welcome you all. This time it is presentation of a case of squint is a very important case. Many people fail there. They may not fail, but they may not perform to a real perfection. So Alan, our star student, will be presenting it. And Nina will be the guru, another star guru. She's well versed in neuro-ophthalmology, squint. So I'm all here. Everybody is here, of course, to listen to the interaction that is going to take place. So I welcome Alan to start the presentation. Right.
Thank you, sir. Alan, can you share your screen?
Yes, madam. One second. Madam, am I audible, madam?
Yes, you're very much audible.
Yes, audible. Yeah, sure.
Madam, is the slide seen, madam?
Yeah, it is seen. It is in the slideshow itself. You can start.
Yeah, you can present.
Good evening, madam. Today I'll be presenting the case of a 7-year-old child, Master Ajwar, who comes from Tattamala and is a student. The mother is the informant. The presenting complaint was tilting of the head to the right for a period of 6 months. The patient was apparently normal 6 months back when his mother then noticed tilting of the patient's head to the right side. His mother states that on attempting to correct the head tilt, the child would immediately complain of a double vision, with the images being separated vertically, and the same would subside on adopting the head tilt to the right. The mother states that the patient had a history of a slowly progressing, painless swelling just below the left eyebrow and above the inner aspect of the left eye, for which underwent a surgical excision 2 weeks prior to the onset of the tilting of the head to the right. There is no history of trauma. There is no history of any altered sense of smell or taste, drooping of the eyelids, defective vision, difficulty in chewing or swallowing, deviation of the angle of mouth, inability to close the eye, hearing disturbances, difficulty in turning the head or shrugging the shoulders, or difficulty in speech. There is no history of any abnormal sensations or weakness of the limbs or swaying while walking. No history of fever, seizures, abnormal eye movements, or deviation of the eye. There were no history of similar complaints in the past and no history of diabetes, hypertension, dyslipidemia, or thyroid disease. There is no similar history in the family and no family history of deviation of eye, and neither a family history of diabetes, dyslipidemia, or hypertension. Birth history: it was a full-term normal delivery with a birth weight of 2.8 kilogram. The child cried immediately after birth with no history of any admission to the neonatal ICU, history of jaundice or feeding problems. The antenatal history of the mother was uneventful. The gross motor, fine motor, social skills, and language development were acquired by the child as appropriate for his age, and there was no delay in attaining the developmental milestones. The child has a mixed diet, appetite, and no alteration in his bowel or bladder habits. There is no history of any chronic drug intake. General physical examination: the child was conscious and cooperative, well oriented to time, place, and person, and well built and well nourished. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or a bilateral pedal edema. The pulse was 88 per minute, normal in rhythm, volume, character, and condition of vessel wall, with no radio-radial or radio-femoral delay. The peripheral pulses were palpable. The blood pressure was 100/70 millimeters of mercury, recorded from the right avid sitting position. He was afebrile and had a respiratory rate of 10 per minute. The systemic examination: the skin, hair, and nails were normal. The musculoskeletal system: the gait was normal with no joint swelling, tenderness, or deformity. The spine was normal. The cardiovascular system: the first and second heart sound was heard with no murmurs. The respiratory system: normal vesicular breath sounds were heard with air entry being equal bilaterally and no added sounds. The GIT, the oral cavity, was normal with the perabdomen being soft, non-tender, and no organomegaly, and bowel sounds were heard. Central nervous system examination: his higher mental functions were normal. The olfactory nerve: there was a normal perception of smell. The second, third, fourth, and sixth cranial nerves would be described in the ocular examination. Trigeminal nerve: he had a normal facial sensation on both sides, with the muscles of mastication being normal. And the corneal reflex and the jaw jerk was present. Facial nerve: there was a normal wrinkling of the forehead with no lag of thalamus. The nasolabial folds were present on both sides and no deviation of the angle of mouth. There was a normal taste sensation over the anterior of the and normal blowing of cheek on both sides. The vestibulocochlear nerve, the RINI test showed an air conduction better than the bone conduction. Test was central, and the absolute bone conduction test showed that the examiner and the patient heard the sound for the same duration of time. The glossopharyngeal nerve, there was a normal taste sensation over the posterior 1/3 of the tongue. For the vagus nerve, the uvular was midline with a normal gag reflex. The spinal accessory nerve showed a normal shrugging of shoulder, and the sternocleidomastoid was normal on both sides. Hypoglossal nerve, there was a normal protrusion of tongue with no fasciculations.
Hello, Dr. Swaroop, could you please mute your mic? Dr. Swaroop, please mute.
The motor system, there was a normal bulk and tone of the muscles, with the power being 5/5 in both the upper and lower limbs, the normal superficial and deep tendon reflexes. The sensory system, the sensations of fine touch, crude touch, pain, temperature, vibration, and position sense was normal. The cerebellum, there was no ataxia, pass pointing, dysdiadochokinesia, or a rebound phenomenon. And for meningeal signs, the Brudzinski and the Kernig sign were absent. Coming to the ocular examination, the head posture, there was a head tilt to the right, the face turned to the right, and a chin depression. This was the picture regarding the head posture of the child. The ocular posture, there was a mild left hypertropia on Hirschberg, which is less than 15 degrees. The lower corneal limbus, if it's compared between the two eyes, just a minimal hypertropia was noted in the left eye. Ptosis, lid retraction, lag ophthalmos or nystagmus. A 3 centimeter long healed semicircular scar was noted, 3 centimeters above the medial canthus of the left eye and 2 centimeters below the medial aspect of the left eyebrow. This was a picture where the child had that swelling, and following that, the surgical scar mark can be seen over here. Coming to the cover test, on covering the right eye, the left eye moved downwards for both distance and near, and on uncovering the right eye moved upwards for both distance and near. The alternate cover test showed a left hypertropia that was noted for both distance and near. The video showing the direct cover test, with the apparently fixing eye, the right eye was first covered. This was the alternate cover test. The prism bar cover test, which was done for distance fixation, showed the values in the 9 positions of gaze as shown in this figure. Coming to the Parkes 3-step test, on primary gaze, a left by R hypertropia was noted, and this hypertropia was seen to worsen on right gaze and the left head tilt. The corresponding values for the alternate cover test done in each the second step of Parkes, that is for the right gaze and for the left gaze, showed the value to be higher in the right gaze and the left gaze, and on the right and the left head tilt. This the video where this showing the third step of Parkes, where the child's left eye, the hypertropia can be seen. On tilting to the same side, the hypertropia is seen to worsen. Coming to the extraocular movements of the child. Irritation was noted in the left eye during dextro depression, and an overactivity was seen in the left eye during dextro elevation. This is actually like the Park's second step itself. So actually on opposite gaze, the hypertrophy is increasing the left eye when compared to the ipsilateral. In dextro depression, there is a slight limitation and an overactivity in dextro elevation, all for the left eye. The convergence was normal. The forced suction test was negative in all directions. The double Maddox rotor showed a 5 degrees of X-cyclic torsion. The Wirtz 4-dot test, the child reported seeing 2 red lights and 3 green lights, which are suggestive of a diplopia. And the diplopia charting showed that there was an uncrossed diplopia with a maximum separation of images seen on dextro depression, suggestive that it could be a left SO paresis. Into the detailed examination of the eye, the visual acuity, the best corrected visual acuity was 6.6 for both eyes. And the wet retinoscopy done using the hometropine drops at 2/3 meters showed the following values. Near vision was N6. The color vision and field of vision was normal. The eyebrows, lids, and adnexa were normal in both eyes. The orbit, the globe, conjunctiva, cornea was clear with normal shape and sensation. The anterior chamber didn't show any cells of flare with a Van Herrick's grade of 3 in both eyes. The iris had a normal color and pattern. Pupil was round and central, 2 millimeters in size with a brisk, direct, and consensual light reflex. The lens was clear with no cells in the antifaces. The IOP reported Goldman both.
There a
Margin.
pause. There was a break. Was it audible for everybody or just inaudible for me?
No, madam, there was a break in the Wi-Fi.
Okay.
I think.
Yeah.
Which slide onwards, madam?
No, it's okay.
Previous slide.
Continue. All these are normal, isn't it?
Madam, it's normal. The indirect ophthalmoscopy, no torsion was noted, madam, both the eyes. Coming to the summary, a 7-year-old male with no known comorbidities and with a history of a surgical excision of a painless, slowly progressive swelling just above the medial canthus of the left eye 6.5 months back, now presented with complaints of tilting of the head to the right since 6 months. Vertical diplopia is present on adopting the normal head posture. The birth and developmental history was normal. His general physical examination is within normal limits. Vitals were stable and no specific findings were noted on systemic examination. On ocular examination, head tilt and face turn to the right was noted with a chin depression. A healed semicircular scar was noted 3 centimeters above the medial canthus of the left eye and 2 centimeters below the medial aspect of the left eyebrow. An L/R hypertropia was noted with the Park's 3-step test showing the hypertropia to worsen on a right gaze and left head tilt. Reductions of the left eye showed an overactivity of the inferior oblique and an underaction of the superior oblique. The forced suction test was negative in all directions in the left eye. Right eye had extraocular movements being full in all directions. The double Maddox rod test showed an X-cyclic torsion of 5 degrees. Best corrected visual acuity was 6.6 in both eyes, with the anterior and posterior segment examination being within normal limits. Visual diagnosis is an isolated fourth cranial nerve palsy of the left eye, possibly iatrogenic in etiology.
Okay, very nice and very lucid presentation. Congratulations on that. So, what is you've come to the diagnosis of isolated fourth cranial nerve palsy, isn't it? So, what is the possible etiology that you have thought about here?
Madam, I think of an iatrogenic etiology, madam, because his previous, there was no previous history of any head tilting for the child. It was post-procedure, and also the site where the surgery was done was at a location where the trochlea and your superior oblique muscle is closely passing by. So there is a possibility it could have been damaged in the process. And his past photographs also does not show any head tilt. which makes a congenital etiology unlikely and
Yeah.
more favorable etiology for an iatrogenic etiology.
So you should put that also in your diagnosis as an acquired isolated fourth nerve palsy, isn't it? So your diagnosis is definitely not a congenital one. It's an acquired isolated fourth cranial. Why do you say it is fourth cranial nerve palsy?
Examination and all is pointing towards superior oblique muscle underaction. The only muscle being the fourth cranial nerve, madam, and my examination did not reveal any other involvement of any other component of the neurological system. So making it an isolated fourth cranial nerve palsy of the left eye, madam.
Yeah, you have demonstrated a positive Parks test, isn't it? And the patient adopts an abnormal head position, which is very typical of oblique palsy. He has a contralateral head tilt. He has a slight chin down, and he has a face turn towards the opposite side, isn't it? So all those are fitting into the abnormal head posture, which is associated with a SO pulse. So your diagnosis should be acute, acquired, isolated fourth cranial nerve palsy, possibly iatrogenic, secondary to a surgery, which was done in the because your history is very typical. It all started within 2 weeks of the surgery. Yeah, what do you think was the swelling? Now, what's the swelling? You didn't tell much about the swelling that he had. What is the nature of the swelling? How long was the swelling present? Was or a congenital swelling?
Madam, the mother stated that around 2 to 3 years the child was aged. She noticed the swelling, but then slowly growing in size. And finally, at the age of 7, that means now, madam, when he was age 7 years, he had it excised. It was a painless, slowly growing swelling, madam. That was from the mother's history, from what I deciphered, madam.
Yeah, so this was a painless swelling in the superomedial quadrant. So what could be the possible, differential diagnosis that you can think of? Common swellings in that region?
Swellings, it could be a dermoid cyst.
Yes. Any history of trauma? See, one important thing you didn't mention in your history was any history of trauma. Did the child have any history of trauma?
No, madam, I mentioned there was no history of trauma, madam.
Mentioned it. Okay. So that's very important to mention because acute swellings can happen after trauma, a fall or an injury in which the trochlea can get damaged. So since this is a swelling which is present since last 2 to 3 years, slowly growing, we have to think of a possibility of a dermoid or a lipoma or a mucocele or all diagnosis of swelling in the supromedial quadrant has to be considered. But considering that it has been there for some time and it was painless, it could have been a dermoid cyst, which is a most common cyst, common swelling in and around that region. Okay. So now let us say, why do you say, let's just go to the exam questions, what they'll ask you, you said it is iatrogenic, it is acquired. So if I say, if suppose this was a congenital superior oblique palsy, how would it be different from this presentation?
Madam, congenital superior oblique palsy, the child would be having actually a head tilt from birth itself, but it could have been unnoticed. Secondly, the child would not complain of diplopia, madam, because the child is adopting that head posture. Yeah. So the child would never complain of a diplopia. Secondly, the child would control that vertical diplopia actually by having very large vertical fusion amplitudes, madam, that you won't see in an acquired one. And also in the acquired ones, the deviation of the eye is actually minimal, but in the congenital one, it has a much larger deviation, madam.
Yeah, and if you had done a binocular vision analysis, these patients, your child was complaining of diplopia, but you could also see whether he was actually having diplopia or if he was having suppression in the first primary position. Rightly, most of them would be having a head tilt right from the birth. You could see their old pictures, look at the family photo albums, and you can see that the head tilt was there right from the beginning. And also another important thing that you can actually see in long-standing congenital superior oblique palsy is mid-facial hyperplasia. Because of the chronic tilt of the face to the opposite side. Like in this case, he's been tilting to the right side, isn't it? So because he's been tilting to the right side, there is actually mid-facial hyperplasia. It will be a little flatter than the opposite side, not develop as well as the opposite side. It's a very characteristic feature which you can pick up as a facial asymmetry. You actually divide the face into two halves. This mid-alar hyperplasia, actually just this region. It's very typical of chronic head tilt to the other side, causing an underdevelopment of the face of that side. So that would definitely tell you that yes, this is a long-standing superior oblique palsy. And the child will never complain of double vision because it's there right from the beginning. He never complain. He might even fuse in the abnormal head position that he adopts, or he may go into a left suppression, but he'll never complain of double vision. Then, as you said rightly, vertical fusional amplitudes are very large. Usually the vertical, what are the normal vertical fusional amplitudes for that we have?
For both distance and near, it's around 2 to 4 prism diopters, madam.
Yeah.
These
so
patients could have around 15.
Very difficult for you to fuse beyond 2 to 3 diopters of vertical squint because of this reason. But surprisingly, when you have a congenital SOP, you may find a lot of disturbance. Yeah, so they may fuse as much as 25 prisms of vertical squint. They may even fuse as much as 25 prisms of vertical squint. That is one thing. Then from congenital, yeah, they will never complain of, they will never appreciate torsion. You can demonstrate torsion on indirect. If you ask them to do a double Maddox rod, they will never appreciate torsion. Congenital superior oblique palsy patients, they do not appreciate torsion. They usually unable to appreciate because it's long-standing, whereas in acquired palsy patients will definitely appreciate subjectively the torsion on a diplopia chart.
Excuse me, madam. Dr. Alicia, please mute. Dr. Alicia. Dr. Alicia, please mute your mic. Okay, thank you.
Yeah, that's better. Yeah. So these are some points which you can distinguish congenital from acquired. Of course, acquired, you'll definitely have an insight, some history of trauma or some other, causes like surgery. What other surgery can, produce iatrogenic superior oblique palsy?
Madam, any surgery done on the extraocular muscle, the orbit, your scleral buckling procedures, then any sinus surgery, especially on the frontal sinus. These are the probable surgeries which can affect, madam, the trochlea and thereby cause a superior oblique palsy, madam.
Any intracranial surgeries can produce SO palsies? Commonly, some intracranial surgeries can produce SO palsies. So any surgery which is done at the tentorium, near the tentorium cerebelli, because the fourth nerve, goes very close to the tentorium cerebelli, it can actually produce. So surgeries in and around that region can produce SO palsies, and the child may come to you with head tilt post a neurosurgical intervention, and you may find that this is an SO palsy, an iatrogenic surgically induced. Sometimes they recover, sometimes it persists. So as you said rightly, local surgeries in and around the superior oblique muscle, then surgeries in and around the trochlea, they're all likely to produce SO palsies, more likely to produce grounds rather than SO palsies unless you damage the muscle or the tendon very badly. More likely they produce fibrosis and restrictive strabismus rather than a paralytic squint, but they can produce paralytic squint also. Okay, so why do you say it is unilateral? Another thing that I would want to ask you is that what if I say this is a bilateral asymmetrical superior oblique palsy? Sometimes you get an asymmetrical superior oblique palsy, isn't it?
Yes, madam.
Is there any way to distinguish?
Madam, the bilateral palsy, the head position would be different. In bilateral palsy, the child would be adopting a chin depression because of that V pattern esotropia to keep the eyes in the upgaze.
Yes.
Secondly,
typical tilt. They usually have a chin down position like this. Yes.
Secondly, they could also have a much more larger degree of excyclotorsion. It would be more than 10 to 15 degrees if you're doing a double Maddox rotus, because it is additive on both the eyes. The excyclotortion adds up in both the eyes. So that is another way we can differentiate between them. Secondly, when you do the Parkes test also, you get a bilateral positive, both the second step. It's a type of reversing hypertropia. That means child is looking towards the right, the left hypertropia increases, and when the child is looking towards the left, the right hypertropia increases. Similarly, your third step, the head tilt test would also be bilaterally positive. So all this would be indicative that it's not a unilateral and it's actually a bilateral SO palsy.
Yeah, so very good. Yeah, so as you said, the chin down posture is more common in bilateral superior oblique palsies, and the vertical deviation is hardly there, because here the main problem is torsion, isn't it? The torsional diplopia is the most annoying thing for this bilateral SO. So they have more of chin down position and also the extrusion. You see, it's going to be more than 10 to 12 degrees. Here you said it is 5 degrees, isn't it?
Yes, ma'am.
Yeah. And again, reversing hypertropia, that is very typical of bilateral SO palsies. That is right hypertropia on right head tilt, which reverses to become left hypertropia on left head, and right hypertropia on left gaze, and which reverses to become a left hypertropia on right, and a V pattern zone down gaze. So all these are very typical of bilateral SOPs, which can be symmetrical or asymmetrical, usually after trauma. I think there is a lot of disturbance.
Dr. Shafna, please mute. Dr. Shafna, please mute. Dr. Shafna. She's not hearing, I think.
As the administrator, you can mute the person, no?
Yeah, actually, we have not put a host for the meetings so that people can enter.
Because it's quite disturbing, yeah.
Yeah,
Anyway,
yeah,
I'm audible to you, no? I'm audible to you?
Yes,
Yeah.
yeah.
So that is something, especially if you get a patient with trauma, you may have to differentiate why is it an asymmetrical SOP and unilateral SOP. Okay, now so what is let's just go into this fourth nerve. So what are the common ways in which the fourth nerve palsy present to you in the OPD? Alan is here. I cannot see him.
Madam, and if I'm audible, madam?
Yeah, you're audible. Suddenly you went out of screen.
Is it visible now, madam?
Yeah.
Thank you, madam. So the presentation of the fourth cranial palsy, you can take the course of the nerve actually. It begins in the midbrain, where we have the level of the inferior collicular. So starting from there onwards, it need not present as an isolated fourth cranial palsy. You can have some associated features and then you can localize it. For example, if along with that, the medial longitudinal fasciculus is very closely running by.
We'll go through that later. You tell me what is the common presentation of SO palsy to our OPD, to the ophthalmic OPD? Okay,
ophthalmic. Okay, madam. The one is the head tilt that they can come with. Second one is they can complain of a vertical diplopia. They can have they may actually state a blurring, especially on down gaze, madam. Like especially on reading.
That's very important. That's what I want to say. Not all patients will complain of double vision, because see, the acquired palsies are very small. There may be 2 or 3 prisms, and many patients may not appreciate it as a double vision. They just say it's blurred. And unless you ask very specifically or you do a double vision starting, you may not get that answer from the patient. Okay, so they may say blurry vision, clear alla, clear alla. That's the typical expression they say. So that cue you have to take, and you have to ask them for double vision. Some old elderly people may not even understand what double vision is. You have to make them understand, because the images are so close, they may appreciate it as a ghost image rather than a double vision. But yes, fourth nerve is the most common palsy which presents to you with to the OPD. Paralytic squint. The most common paralytic squint that we as an ophthalmologist see is fourth nerve. Why is that so?
Madam, the fourth nerve itself is special in its features compared to the other cranial nerves. It's the longest of the intracranial course. It's the thinnest and the most slender. It is the only one to actually have a dorsal exit from the brainstem, so more prone to trauma. And it has got the fewest axons present within it. So all these reasons make it a nerve highly susceptible to damage, and thereby a fourth cranial nerve palsy becomes the most common one.
Yeah, so very good. So it has, as you said, it has it was one of the longest intracranial unprotected course. So that is that is what makes it vulnerable to, trauma. And though it's the sixth cranial nerve which gets affected in raised ICT, a few times we do see SO palsies also with raised ICT, maybe for the same reason. And also in neurosurgical procedures and surgical procedures of the brain, any surgery, because it has a course along the tentorium cerebelli, it passes under the edge of the tentorium cerebelli, it can also be injured in surgical procedures. So it's very peculiar and indeed very different from the other cranial nerves. And what is the other peculiarity of the fourth nerve? So all these you have said, it's dorsally, it is a slender nerve, it has the longest intracranial course, and what is the other specialty from which is different from the other cranial nerves? It's a crossed cranial nerve, isn't it?
Madam, it's a cross. Yeah. It's the only one to show decussation.
Yes. So if you have a patient who comes to you with a a nerve palsy, and you find it difficult to localize, and you find it is nuclear cause, think about that, because immediately after it emerges, the anterior medullary velum, it crosses to the opposite side. So you may get a contralateral trochlear nerve palsy in some lesions. When unsuspected lesions, you may get a contralateral trochlear nerve palsy, especially when the level of the midbrain. Okay, so it's a cross cranial nerve. So immediately at the anterior medullary velum, just after the velum, at the level of the inferior colliculus, it originates, and then immediately at the anterior medullary velum, it decussates, and it actually supplies the SO muscle of the opposite side. So it's a cross cranial nerve. So that's something that we need to keep in mind. Yes, so now you can tell me the anatomy and tell me what are the possible ways just for everybody. So you can just roughly tell me the anatomy of the trochlear nerve.
The trochlear nerve, the nucleus of the trochlear nerve is in the midbrain at the level of the inferior colliculus, and then it emerges out as a fasciculus, and the only one to come from the dorsal aspect of the brainstem. Then it will wind around the brainstem, around the cerebral peduncle, and travel in the subarachnoid space. Then as it goes forward, it will pierce the dura mater of the dural venous sinus, that is basically the cavernous sinus, and travel along the lateral wall of the cavernous sinus, with the third cranial nerve lying above it and the first division, the ophthalmic division of the fifth cranial nerve lying beneath it. After exiting out from the cavernous sinus, it passes into the superior orbital fissure, and then enters into the orbit, where it finally goes and supplies your superior oblique muscle. Presentations, madam, it can.
One second. We'll go. Where are the places you can get an isolated fourth nerve palsy? In this course, where are the areas that you can get an isolated fourth nerve palsy?
Madam, isolated one, it could be the level of your superior orbital fissure, madam, within the orbit itself. Then subarachnoid course also, as it just winds out subarachnoid, there also it can be an isolated involvement, madam.
Yeah, so in the subarachnoid space, just like the third nerve, it is actually going between the posterior cerebral artery and the superior cerebellar artery. So just like the third nerve, it is also susceptible to aneurysmal compressions and all, but it's very rare. Unlike the third nerve, it is not a very common cause, but there are some reports of aneurysmal SO palsy. So you can keep that in mind, that in a subarachnoid space is one place where it is isolated. Yeah, then in the cavernous sinus, of course, it is on the lateral wall with the third nerve and the V1 and other nerves. So if you isolated palsies are rare. In the orbit, on the superior orbital fissure, again, it is rare to get an isolated SO palsy, because you have the lacrimal frontal, then the trochlear and other cranial nerves associated. But once it enters the orbit, yes, you can get an isolated SO palsy due to some either orbital trauma or surgeries in the orbit, or direct, then the next place that you can enter, you can get this is the trochlea. So trochlea, can you tell me a little about trochlea? What is the importance of trochlea as far as SO muscle is concerned?
Madam, the superior oblique muscle, it is actually the longest of all your extraocular muscles, having a total length of 60 millimeters. So it's actually origin is from the supromedial aspect, supromedial to your optic canal. The muscle runs anteriorly, just along the junction of the roof and the medial wall of the orbit. Then as it reaches the anterior-most portion, you have a fibrinous pulley there, madam, that is called the trochlea. It's actually attached to the spina trochlearis of the frontal bone. And actually
Yes.
this trochlea, and just around 10, maybe 1 centimeter proximal to the trochlea, the muscle becomes tendinous. The tendon then goes inside the trochlea, winds, and again turns back, madam. So basically your trochlea is acting like a functional origin of your superior oblique muscle, whereas actually the anatomical origin was in the supromedial to your optic canal. And then the tendon again, as it winds around the trochlea, it then goes on to the superolateral aspect of the globe, the postrotemporal aspect of the globe, and again it fans out and again forms a muscle and then gets attached to the postero-superior aspect of the globe, madam.
Under the superior rectus, yeah. So very good. So the trochlea for all practical aspects is the functional origin of the superior oblique muscle, because first of all, 2 things it does. It changes the direction of the SO muscle. So a muscle which is originating on the medial aspect is, the direction is changed and it is getting inserted in a fan-shaped position into the postero-superolateral compartment of the eye, isn't it? So, and it sort of it acts like a pulley, isn't it? So the trochlea is very of paramount importance because diseases of trochlea can affect. So what do you think happened to our patient here? What possibly could have gone wrong? What surgery they must have the trochlea, or what do you think could have happened here?
Probably the trochlea was dislocated, madam. Maybe the tendon got cut off. It is very closely located to the trochlea, madam.
Did you palpate that region? Did you palpate and compare between the 2 eyes? Was there any difference? Was there any swelling? Or was it having any pain?
Nothing significant, nothing to compare with the other eye, madam. Nothing significant, madam. Just saw the scar mark there, madam. Mainly, but in palpation also, couldn't appreciate a difference, madam, compared to the other eye.
Possibly there is no fracture of trochlea. Possibly some of the fibers, some of the maybe the more fibers, a considerable amount of fibers may have got detached. Because if the trochlea usually had to be detached, it has to have a considerable amount of trauma, or in surgery it can happen if you don't identify the trochlea properly. You can detach it, but maybe I would rather put it as maybe some superior oblique fibers could have, the tendinous fibers are very thin, isn't it? It's very easy to mistake them for even a Tenon's capsule sometimes and cut them off. So yeah, so we will actually telling about the anatomy of the 4th nerve. Yeah, and so I think everybody knows now, is aware. He has nicely explained how it originates, decussates, and travels, and comes to the insert. And also a little bit about the superior oblique muscle. Now, what are the peculiarities of the superior oblique muscle?
The peculiarities, it is one of the longest extraocular muscle, madam.
Yes.
I mean the longest, 60 millimeters. Then it begins as a tendon. It then again turns into a muscle belly. Again, there is a tendinous portion, and then finally it again forms a muscular portion, madam. The entire superior oblique muscle. Then its primary function of the superior oblique muscle is the intorsion of the eye. And then the fibers also of the superior oblique muscle, it fans out. So, and these fibers have got different function. The anteriorly most located fibers are the one that is responsible for intorting the eyeball, whereas those posteriorly most attached fibers are responsible for actually depressing the eyeball. So even when surgically manipulating, the fibers have to be separately considered, madam.
So is it normally when you're doing extra, you must have seen some muscle surgeries, isn't it? So when you're seeing some muscle surgeries, is it, do you normally visualize the superior oblique muscle? Have you seen, or do you have to really go and look for it? Have you seen during any muscle surgeries the superior oblique tendon?
Madam, actually, I don't know about it.
Yeah, so that's not easy to see, and sometimes it can be easily mistaken for a thin, frenulum or a thin Tenon's capsule and cut off. But it's not that easy to damage it because it's so thin and very transparent. It almost looks like a thin cartilaginous fiber. So it is well protected under the superior rectus muscle. So unless you look for it, and you may not find it, and you may have to dissect it out when you're doing the surgery. So, but if you inadvertently go into the supranasal compartment, you can actually damage the tendon of the superior oblique here. But in the superolateral compartment, it is more or less covered under the superior rectus muscle. About you'll have to go a little posterior up to the muscle, and then see that, look for the tendon. And if you're doing surgeries in superior rectus, you can actually see how nicely the muscle goes under the superior rectus. And there is a frenulum which connects the superior rectus to the superior oblique. And so that has to be dissected in surgeries. Otherwise, you may pull the superior oblique along with your superior rectus wherever you take it. So it is also a special muscle. It is almost tendinous. It has got one of the longest tendinous tendon lengths, unlike the inferior oblique muscle, which is mostly muscular. So this is a very thin, friable muscle which can easily be damaged. And it's an unforgiving muscle because I remember our teachers telling that the superior oblique is like father. You don't play with superior oblique, but inferior oblique is like your mom. She will forgive you. So you can do all sorts of surgeries with the inferior oblique and still get away with it. But when you're doing a surgery on superior oblique, you have to be doubly sure that you know what you're doing. So because it's very important, and it acts in, main action is in down gaze. So you have to be very careful about what you're doing. So I think we just covered a little bit about the about the anatomy of the fourth nerve, and also about the superior oblique tendon. So one thing I just wanted to ask you is, did you check the binocular vision of this patient? Was he having diplopia? Did you do a Würzburg test or a stereopsis analysis?
Würzburg test, madam. He was complaining of a diplopia. He actually reported seeing 5 colors, 2 of the red and 3 of the green, madam.
Yeah, so that is again very suggestive of an acquired cause here. And anyway, your history is very clear that it is an acquired cause. So just a few other points. Can you put that, can you go back to your slides? I just thought I'll just mention a few points in your slides.
In the beginning, madam?
Yeah, just go back. Some things which I thought, you could, yeah, all this is good. Just go to the clinical examination part. Yeah, this is also okay. Yeah, this next one. Next one. Yeah, next, go to your APCT, PBCT measurements, prism bar cover test. Yeah, I just want to tell you here, no, it looks a little confusing. You have written 18 prisms base up, isn't it? Base up in front of which eye?
Madam, the right eye, madam.
Yeah, so it is very confusing. No, you have said left hypertropia, isn't it? So by default, when you're mentioning the squint, we always, even if it is the pathology is in the hypotropic eye, usually the dictum is to mention the hypertropic eye. So we will say a left hypertropia. So if you're writing base up, you should mention that you've kept the prism in the right eye. So if you may kept the prism in the right eye, what is the probable problem here? This is an incomitant squint, isn't it?
Yes,
and what are you measuring then?
If I'm placing it there, I'm actually measuring the secondary deviations.
Yeah, so I don't want you to measure the secondary. You will overestimate the deviation, isn't it? So when you are mentioning your PBCT measurements, and here the pathological eye is the left eye, isn't it? So it has a left hypertropia. You can mention, I don't know how much it would come when you do keep the prism, because the right eye is fixing eye and left eye is unmaintained. You can put the prism in the left eye because the deviation of the paralytic eye is what we want to measure. Because if you're planning a surgical intervention or prisms or something, that's the deviation that you want to correct, isn't it? You don't want to overcorrect it. So keep the prism over the paralytic eye, and you can write it as 18 or 6, whatever it is, 14 prisms left hypertropia, because that will be more specific. Here it becomes a little confusing whether you have kept it over the. Okay, so when you write like that, you please put it over the paralytic eye. Otherwise, you will erroneously measure the secondary deviation. and your values will be wrong when you're doing a surgical adjustments or a prism correction, because you want to put the prism over the left eye.
Left eye.
Otherwise, it's good because here it shows that the left hypertropia is increasing in the right gaze as well as in the down gaze. And also in exam, you can also put a head tilt like a V and show it increases on right head tilt or left head tilt. Have you put that? I think next slide you have put it, isn't it?
I've just shown the measurements one, yes.
Yeah, so rather than putting base up, you can write left, left hypertropia of 25 prisms was there when the prism was kept in front of the left eye.
Oh.
Okay, next slide. Yeah, so yeah, I think, yeah, this is all good. How did you do the force duction test here? Did he allow you to do the force duction test? I would really ask you this, because I know no child of this age usually will allow a force duction test.
Quickly just tried, madam.
Yeah, it's okay. It's okay if you don't try, if you say child was uncooperative, because most of the time a force duction test on superior oblique is difficult.
Well, yes, madam.
How do you do a force duction test on superior oblique?
You will have to see which superior oblique. Since I'm looking at the left eye superior oblique, I will have to take, after anesthetizing the eye with topical anesthetics, I'll have to take 2 forceps and hold it 90 degrees to the action of the muscle. So since it is the left eye, it will be at the 1030 position and one opposite it. And now to keep the superior oblique under stress, I will actually have to push at the globe, because the superior oblique is coming anteriorly. So I need to keep the muscle taut. So I push at the globe, and then you will have to just rotate it around and see whether how much of resistance or how much of ease with which you're actually able to rotate the globe.
So no child is going to allow you to do that. So you shouldn't mention it. You can just say, I will do it. I would do it. It has to be under sedation. So this is an exaggerated force duction test of Titan. Basically, what you're doing is you have to retropulse the eye. That is the basic difference when you're doing an FTT for rectus muscles and oblique muscles. For a rectus muscles, you have to propel it a little bit, not too much, so that you get able to understand the resistance. But for the oblique muscles, you have to retropulse the eye a bit and put the tendon at stretch. So in this case, you want to move it from the to the supranasal compartment. So you have to hold it a little diagonally, either let us say 2 o'clock and 7 o'clock position, and then rotate it from the down position to medial or supranasal compartment, and see how much of the cornea can be pushed inside. So if the corneal limbus goes very much into the supromedial fornix, then it's a very lax tendon. But in case of a Brown's, you may not be able to push it like that. So that is how you understand, and by experience you understand the tightness or the laxity of the muscle. So please, I think it would be wise not to mention it in a child, and even adults will not usually allow you to do a force duction test on superior oblique, because it involves you to retropulse the globe and put the tendon at stretch, which requires a bit of manipulation. So, so just that word of advice. Yeah, the double Maddox root. How do you do a double Maddox root? So you've said a 5-degree extorsion.
Madam, after placing the trial frame, you're taking the Maddox rod and you're placing it such that the Maddox rod basically is going to convert that light source into a line perpendicular to how you place it. So I wanted the lines to be horizontally placed. So I kept the Maddox rod vertically on the trial frame. And after that, I asked the child like how is he actually put a light source, and asked the child how the lines are appearing to him. So he showed me that it was like tilted. So I asked him like just to touch on the tip of one of that. I showed him taught him how to touch the tip of that Maddox rod and to just move it in whichever direction he wants to, and so that he can just make the lines to parallel Maddox. And he just moved it.
Yeah, like the parallel tracks of a railway track. So most often the patients get it right because they themselves are seeing it. You can put 2 colored Maddox rod, 2 different colored Maddox rod to distinguish which which is the touting eye. And also make sure if you can dim the room lights and give it a nice sharp source of light, then you can appreciate the lines very well. That's very good. So next slide. Yeah. Can you describe this diplopia chart?
This is a diplopia charting. with the picture being represented at the patient's view, madam, which is done at a distance of.
Very good. That should be mentioned because this is as how the patient. Imagine you are the patient, and this is how it is seen by the patient.
This was done after wearing the Armstrong glasses and at a distance of 120 centimeters. Among the 9 positions of gaze, the diplopia charting shows an uncrossed diplopia, as the red color is seen on the right side and the green color is seen on the left side. And among the 9 positions of gaze, the gaze that showed the maximum amount of separation was the dextro depression. And there are 2 possibilities there. Either it could be your right inferior rectus or your left superior oblique. But since it's an uncrossed diplopia, it's likely that it could be left superior oblique involvement, madam, from this diplopia chart.
I just wanted to tell you that you can actually tell that this is the left SOP by just looking at diplopia charting, because it's an uncrossed diplopia and it is increasing dextro depression and down gaze. Not only is there a vertical deviation, there is also a distortion. Can you appreciate that? The green image, the inner part is tilted towards this. So when you get an intorted image on diplopia charting, it will translate to an extorsion, isn't it? It's just the opposite. So just by looking at the diplopia charting, you can just directly come to the conclusion that this is a left superior oblique palsy, because the vertical deviation is increasing in dextro depression, and the torsion is the inner part is tilted towards, showing that it is possibly an extorsion, isn't it? So that point can also be added, which can be very nicely demonstrated in this diplopia charting. And sometimes you also may be able to appreciate the horizontal deviation. If you have a VESO, you can appreciate that the horizontal deviation is getting worse on down gaze. Okay, next one, please. Yeah, all this is good. I think now everything is over, isn't it? Yeah, refraction is normal. So what are you going to do for this patient?
For this patient,
I think we are going to almost, is it 1 hour meeting?
Yes, ma'am. It's 1 hour.
Yeah.
So
what do
you can continue.
Yeah, so we have like probably, we know the diagnosis is crystal clear, it's staring at our face. So what can you do for this patient?
Madam, surgical line of management itself would have to be followed, madam, because the head tilt, if adopted by the child for a long duration of time, it could lead to those facial asymmetries and shortening of those muscles. So even if later you plan for the surgery, that head tilt may still persist, and you're trying to give that binocular single vision, at least in primary gaze and down gaze. So usually in all these superior oblique muscle palsies, its antagonist muscle, that is the inferior oblique muscle, usually has an overactivity. So, and this patient had on primary gaze around 18 prism diopters, around 15 prism diopters can get corrected if you actually weaken the inferior oblique muscle ipsilaterally of the eye that is being affected. So a weakening procedure on the inferior oblique muscle, that is a recession of the inferior oblique muscle.
Yeah.
I would.
Yeah, so I would remeasure with the prism over the paralytic eye again. And I would confirm your measurements, because I may get a little lesser values than what you have measured, because you've kept the prism on the right eye, isn't it? So I would remeasure and I would confirm. And yes, and also you got to do an FDT on table and see how what is the status of the superior oblique tendon, whether it's very lax or what is it. And yes, the most common surgery that we do is the weakening of the ipsilateral antagonist. That's the there is considerable overaction, isn't it? Around +3 overaction of the inferior oblique is there. This thing is to reconfirm your amount of deviation, and if it is around 15 or less, unilateral inferior oblique recession is the first surgery of choice. If it doesn't get corrected, then you may have to think about a second muscle surgery here. But suppose if it is an iatrogenic cause and you may think it may improve, in the interim period, you can try prisms. In this case, you'll have to use Fresnel prism, because the small prisms cannot be ground in glasses. You'll have to use a Fresnel prism just to be stuck under the glass. and make sure that the child is able to use both the eyes. Okay, so I think, is there, can I ask more questions, or is there is it over? The time is over. I don't want to, take.
And I think we can go on for 10 minutes, madam.
Yeah. So, just one thing, why do you get a hypertropia when you tilt head to the same side in you said no, when you do the Parkes test.
Yeah, okay.
In a superior oblique palsy, you get a hypertropia which reduces on contralateral head tilt but increases on ipsilateral head tilt. Why do you get that?
Madam, if you're doing a contralateral head tilt, so naturally your extorters have to come into action to correct the intorsion which is happening as you're going for a contralateral head tilt. So there are the muscles which are actually causing, which can help in causing the extortion of the eye. That is basically your inferior oblique, inferior rectus. Both of these muscles are actually intact. So they and they have vertical actions. These both muscles which are coming into play, but they have got opposite vertical actions. That is, your inferior oblique has got a vertical component of elevating the eye, whereas your inferior rectus is actually supposed to depress the eye. So those vertical components will get cancelled out, and the so the hypertropia is not seen on the contralateral head tilt. But supposing it's an ipsilateral head tilt, it is your intorters which have to come into action. Your intorters are your superior.
Why?
Why mean?
Yeah. Why do you get when you tilt your head to one side? Why is that the intorter has to? It is right. What you're saying is right, but why? That's a normal tilt reaction, isn't it? Normal reflex action, isn't it?
Madam. So when you tilt to the same side, the muscles coming into play to intort the eye are actually your superior oblique and your superior rectus. The problem is superior oblique is weakened, and if you look at the vertical actions of these muscles, superior oblique is supposed to depress the eye, whereas superior rectus is supposed to elevate the eye. Since you have a weak superior oblique and a much more stronger or normal superior rectus, the hypertropia would actually increase on an ipsilateral head tilt.
Yeah, you're right. So to understand that better, you need to know what happens when you tilt your head to one side. So suppose you tilt your head to the right side, isn't it? So the right-sided muscles will have, because it's a reflex action, the eyes will rotate to the opposite side. Just like when you turn your face to the right side, eyes are going into lever version, like that. It's a reflex action, just like the oculocephalic reflex. So when you tilt your head to the right side, the right eye muscles intort and the left eye muscles extort. That's the normal reaction. When you have an SO palsy, as you said, the right eye intorters, they start playing. So with the right eye intorters are superiors, isn't it? The superior oblique and the superior rectus. So normally the elevating action of the superior rectus is matched by the depressive action of the superior oblique, and there is no hypertrophy. But in case of an SO palsy, because there is no SO muscle which is acting, there is unopposed action of the elevation of superior rectus, which manifests as the positive head tilt test. So that's very good. You have understood your basics. I'm happy to know that. Okay. So so I think that was something which some examiners will ask you, like, why do you get this positive head tilt? And one more small tip which I want to tell you is that whenever you get this vertical muscle palsies for the exam, people are very scared because they have to remember Parkes test, turn face. So one thing which I have found very easy to understand is, if you have an isolated vertical muscle palsy, first thing that you do is a face turn. No, you see which muscle is underacting or overacting in the gaze. Instead, you do a head tilt first. You can write the same in the exam, but in a practical purpose, you do the head tilt first. For example, if you have, in this case, you have a left hypertropia. In the left hypertropia, first you do the head tilt test. So if the left hypertropia increases on the same sided head tilt, it is an oblique muscle. Either it is the left superior oblique or it's the contralateral inferior oblique. There is no two way about it. So once you have ruled out the obliques, it's very easy to know which is the rectus muscle. So it is the oblique which is most confusing. Otherwise, you'll have to take a paper and pencil and write on the gazes, isn't it? So if the left hypertropia increases on the same sided head tilt, it is an oblique. Either it is a left superior oblique or the right inferior oblique. And if the left hypertropia increases on contralateral gaze, that is on right gaze, it is the left superior oblique. So simple. But if the left hypertropia, which is increasing on the left head tilt, increases on the left gaze, it is the right inferior oblique, which is northward. So these two permutations will immediately rule out the obliques. Then you know the rectus muscles, which you know they act in abducted position. So it's very easy to, and the head tilt will not be increasing on the same side. So it's very easy to, and superior rectus will, under action will be more in elevation, and inferior rectus under action will be more in depression. So it's very easy to do that. So for all practical purpose, this is the Kenneth Wright's modification of the Parks test. So Wright's modification of the Parks test is an easy way to figure out which is a paralytic isolated vertical muscle by doing the head tilt first. So that's something which you can actually use in your exam, but in your practical use. But in the exam, please write it as it is, because examiners will like it, I think, the way it is mentioned. So I think I don't want to be the monotonous examiner here. He has presented well, and I think sirs are there. Mahadevan sir, Sahasranamam sir, Sushila ma'am, they may want to add in something.
I'm here, Nina.
Yes, ma'am, you want to add in something?
It was very, very well presented by the person, and also the Guru also is very well versed. What to tell? It was very, very advantageous. I could remember so many things which I had forgotten actually in between. Thank you.
So Mini, are we going to wind up, or any comments or any questions are there in the chat box that we need to address?
Right now, I don't find any questions. One thing I can ask, Madam, is when is there a minimum period of intervention so that the head posture is not maintained?
Yeah, usually you see, in this child, what I would do is I would put him on patch also, because I would want to see his Bird's dot test and his stereopsis for near. And if there is a threat of him going into amblyopia, it's a good idea to put him on part-time occlusion therapy so that he doesn't go into. But most of the time, if he's adopting the head posture, he's trying to fuse, so he's binocular. But still, it'll be a good idea to put him on patch. And we do give sometimes, like in the interim period, at least I wait for 6 months. As here also, we have waited for 6 months since the surgery.
Yes.
Yeah, we would wait for 6 months. And in the interim period, what you can do is I have given frenal prisms to even kids also. So frenal prism is a good option to give. Measure because if it's only 12 or 15, it can be easily stuck under the left eye, under a plain glass. And you may find that the child's head posture will improve, and it will also give you a sort of simulated idea how the post-surgery, his head posture would be. That's not a bad idea. Then, then I also want to rule out, I would definitely do an imaging here, because there has been a surgery, isn't it? I would want to do an imaging, and I would also want to rule out, I would want to know if the trochlea is, as he said, is there a fracture of the trochlea? Is there any misplacement? So I would want to. Yeah, I think there was a break. Yeah. Can you hear me now?
Yeah, I can.
Yeah, I would want to also see if there is any, abnormality in and around the trochlear region, and better to do an imaging and see what is really happening there. And if there's nothing, that you can do, if there is any signs of inflammation, it would be worthwhile to give a trial of steroids if you're seeing in the acute phase. We do give a trial of steroids to such children. So that is something that you do. Then after 6 months also, if there is no improvement, yes, go ahead and do surgery, because these children can go into amblyopia because he doesn't have very large functional amplitudes now, and he may not be able to keep the head tilt for a very long time. He can actually, and he'll lose out on lots of other activities in school because of all these things. So it's a good idea to do the inferior oblique recession. There is no harm. Just a word about, what are the peculiarities of the inferior oblique muscle? Just like the superior oblique also, it has some peculiarities, isn't it, Alan?
Yes, madam. It's the shortest of your extraocular muscles. It's purely fully muscular. It is taking its it's very closely related to the macula at its insertion point,
Yes.
and even related to the posterior vortex vein at the insertion site. Then it is actually it's the only extraocular muscle to actually have its anatomical origin from the anterior aspect of the orbit.
Yeah, outside the annulus, isn't it? Yeah. Yeah, so that's very good. So when you're making the incision, the very important to know the landmarks here. As you said, you make an incision in the infralateral compartment, 8 millimeters from the limbus. Why is that incision 8 millimeters from the limbus? That's got very significant surgical importance. Because just behind it, about 10 millimeter from the limbus, is your orbital pad of fat. Okay, and your vortex veins, all these are very closely so you don't want to disturb the orbital pad of fat, because in that case you may get a fat adherence syndrome. And this 8 millimeters incision, the first incision is made on the conjunctiva parallel to the limbus, and the second incision is made in the Tenon's capsule perpendicular to the first incision. So once you get these two incisions, you come down to the sclera, and under direct visualization, you can hook the inferior oblique. It acts like, it's almost lying like a swing or a hammock between the lateral and inferior rectus. So under direct visualization, you hook it. And before hooking, if you can visualize the vortex vein on the near the inferior rectus origin insertion, that will be good, because then you don't damage it. Because you cannot cauterize the vortex vein. If you damage it, it will bleed, and you just have to wait, apply pressure, and wait for the thing. And no hesitant cuts here, because hesitant cuts means there will be bleeding, tenons. You don't want to open the posterior tenons. All the surgeries are going to be done in the anterior tenons opening, and it has to be a single clear opening and hooking the muscle. Then once you disinsert it from the, where is it inserted? It's inserted. The inferior oblique insertion, you said it is from the near the
the postero-inferior aspect of the globe, madam, very close to the macula, madam.
Yeah, it's actually inferior to the lateral rectus, you see, and then you see it's inferior about 8 to 10 millimeters from the inferior, in the inferior part of the lateral rectus. It's inserted in the infralateral compartment. And importance, as you said rightly, it's directly about 1 to 2 millimeters overlies the macula. So you don't cauterize that area, because you may injure the macula inadvertently. So, and you don't dissect too much close to the inferior rectus muscle, because your neurovascular bundle is there of the inferior oblique. So you don't want to damage that. So because then you end up having, what is the other possibility that you can get if you dissect close to the neurovascular bundle of the inferior oblique? You may get an iatrogenic something else. What nerve goes through it? The nerve to the inferior oblique carries some other fibers, isn't it?
The infraorbital nerve, madam.
No, the nerve to the inferior oblique, you can get an iatrogenic Addy's pupil. Why? What is the nerve to the inferior oblique carries the short posterior ciliary nerves to the parasympathetic system, isn't it? Which supplies the sphincter. So that's one easy way to get an iatrogenic Addy's pupil. So don't dissect much close to don't dissect the inferior oblique muscle close to the inferior rectus. Whatever dissection you're doing is towards the lateral rectus as at its insertion. Once you disinsert it, you reattach wherever you want. There are many types of recessions and advancements, which is beyond the scope of this class. But one important surgical anatomy would be not to touch upon the neurovascular bundle, because you can get an iatrogenic Addy's pupil. So that's something about contrast between superior oblique and inferior oblique, but both are interesting in their own ways.
Madam, so superiorly, there is no need for a dissection to find out the area of trauma.
That's what. So we will image. So suppose there is a fracture of the trochlea, or and the trochlea is, if there is a fracture of the trochlea and the tendon is disinserted or something, then you can go in and try to reattach the trochlea. That is something you can do. But I think most of the time it will be picked up. If it is picked up immediately, it works. But I don't know after 6 months how effective it is. But the safer surgery would be to do an inferior oblique recession here. Because sometimes I have seen when you go after a long time and touch the trochlea, in fact, you get an iatrogenic Browns. which sometimes may correct the superior oblique palsy, surprisingly, but we don't know how it will turn out to be, because a Brown's is anyway better than an SOP, isn't it? So it's worthwhile. You can go ahead and explore. If you find something on imaging of fractured trochlea and disinserted tendon, you can try to reattach. But if just one or two fibers, I mean, if you don't see anything anything definite on the imaging, the safer option is to go for a inferior oblique surgery. In traumas, traumas and all, we have done that. Like we have gone ahead and explored the trochlea, and we have reattached the trochlea.
Ellen, have you done an imaging? I think we have done, right?
No, madam, there was no imaging. It was actually the pre-operative for the swelling, madam. They had their old records regarding the swelling.
So I would like to thank Dr. Neena, madam, for the wonderful discussion. And actually, we had maximum attendance today so far. We have not had so many students. And I would also add that this is the last Paathsaala of the present team of office bearers. So we are going to have a fresh session from next month onwards. Thank you so much for all those who attended, and thank you, Ellen, and thank you, madam.
Thank you, Ellen. You've been you did very well, and it's very difficult to understand some concepts of squint and strabismus. So I think you have a good future in pediatric ophthalmology and strabismus if you like the subject. Okay, and thank you, Mini, for the wonderful camaraderie and ambience. And I'm so glad to be part of the RIO faculty and the group here, because I was once a PG student there, and I'm deeply in gratitude to my teachers from whom I learned some of the essentials of strabismus, especially Dr. Anita Balachandran, Dr. Sushila ma'am, Dr. Sahasranamam, and Dr. Mahadevan sir. So many more are there, but I remember my days in RIO, and I'm very happy to be here today.
Thank you. Good night to all. See you later.
Good night. Yeah.
Thank you.